Yes, hello, good morning again. I'm here again with an old lady. I would like to introduce you shortly into the case. I feel that this is of interest because this interventional therapy is following a failed bypass surgery. So I have nothing to disclose with respect to this particular case presentation. So this lady had symptoms of rest pain at night at her left leg, and in August 2018 she underwent a venous bypass graft operation. The graft was originating from the mid part of the SFA down to the proximal anterior tibial artery. Already 2 years ago, or 2 years earlier, before this bypass surgery, she underwent a local thrombectomy and embolectomy due to an embolic event into her popliteal and below the knee arteries. She's known with coronary 3-vessel disease and also underwent 2 interventions in her coronary circulation in the past. She's presenting with the typical risk factors except diabetes mellitus. Next slide, please. These are the pre-interventional workup examinations. So first of all, the duplex examination showing a clear critical deterioration of the foot perfusion, ABI at rest 0.4. In duplex ultrasound, we could find an occlusion of the SFA and popliteal artery with some reconstitution of outflow at the level of the mid-calf. And now I'm presenting you the angiogram. You can see during this surgical reconstruction, there was a TA of the left common femoral artery done. There is a moderate lesion at the origin of the SFA persisting. Then we see the occlusion of the distal SFA and proximal popliteal segment. We don't see a stump of the former venous bypass. I had a look into the operation report, and the vascular surgeon did report that the veins he did use had been of, well, let's say moderate quality, and he had to perform a kind of composite venous graft using the left and right great saphenous veins. Then we see a small segment of reconstitution of popliteal artery in the middle part. And then we have the outflow with diffuse disease of the anterior tibial artery, which was the target for the bypass graft. And we see some refilling of the peroneal and in part also of the posterior tibial artery. So this angiogram was done in another institution, and the patient was sent to our institution for recantilization of this chronic occlusion. So what is the intention? Next slide, please. Well, I've chosen an antiquated 6-French access. First of all, I usually try to get access to even chronic occlusions in a kind of intraluminal lesion crossing attempt. Then the idea was, if this may work, I would either use a cutting balloon or an atherectomy device. A reason for a focal force balloon was basically that 2016 there was a patchplasty done in the popliteal segment, so I assume or I expect to find some scar tissue which may be rigid against simple balloon angioplasty, and then further on I will perform a drug-coated balloon angioplasty of the popliteal artery, despite the recent talk you have heard about the Katsanos meta-analysis. In addition, I will definitely improve the outflow in some way. So next. Now we can go live, but probably are any comments from the podium so far with regard to this case presentation?
This is a very complex case. I think we'll be very interested to see what your approach is.
Okay. Yeah. Well, then let's go live to the screen here. Well, again, this is now the angiogram showing this moderate osteolesion of the SFA. Then we have very diffuse disease of the SFA. We have this occlusion of the popliteal artery, which is showing a lot of media calcification, but also some intraluminal calcium. I will show you more clearly in a couple of seconds. Then we have here the reconstitution of the bifurcation of the peroneal and posterior tibial artery with an occlusion of the posterior tibial artery in the mid part of the calf, and the peroneal seems to be patent. And then we have a long collateral vessel which is anastomosed to the distal segment of the anterior tibial artery, which will be shown more clearly with subtraction angiography. So again, this is DSA. Here we have some reconstitution of the proximal anterior tibial artery with occlusion starting in the proximal segment. We have the occlusion of the tibiopineal trunk. And this is now my recanalization attempt.
Dr.
So
Zeller?
what I use in such kind of lesions, yeah, okay.
Quick question. What was the time frame between the angiography at the outside institution and today? Because it looks like that island of reconstitution in the popliteal has disappeared.
No, it's still present. I will show you. It seems to be a little bit shorter than it was initially. So the angiogram was performed about 4 weeks ago. So it's about 1 month's time difference. So what you see now here, this is a 5-French diagnostic catheter. It's a vertebral configuration. And you can nicely see the calcium in the popliteal segment inside the occlusive segment. Then this is again the angiogram. Now the attempt to cross the lesion. I'm using, now you see the reconstitution of the mid part of the popliteal. Well, it's a very short segment, but still patent. And the guide wire I did use for the crossing attempt is an 18,000th advantage glide wire. And you may see here in this run that I was most likely able to cross the lesion in the true lumen, even if it kinks a little bit, but here it's going down again. And step by step, it's simply rotating the guide wire with some pressure. I went down further and was then connected to this short segment of reconstitution of the artery in the mid part of the popliteal segment. What you can see now, I did follow with my diagnostic catheter. This is an injection of 2 cc of contrast. We see the refilling of the anterior tibial close to the origin. Then the next step was to further advance the guide wire. Initially, I went into a side branch. Then I did add one. Now you can see the side branch where the guide wire went in initially. And I did reorientate then my catheter, my vertebral catheter, towards the mid orientation. And by doing that and advancing the guide wire, I was able to stay true lumen also here. And this is now a selective injection into the origin of the anterior tibial, and you can see that there is a total subtotal occlusion in the proximal and mid part. This is a pre-dilatation of the anterior tibial with 2.5 millimeter, and this is the angiogram I obtained just simply after crossing the popliteal artery with the guide wire and the support catheter. And what you may see here is that there is some thrombus in the middle part here of the popliteal, and just proximal to the occlusion, there is the Phoenix atherectomy catheter already in place, which I was using then to cross the lesion twice. So the Phoenix atherectomy catheter is a front-cutting device. Here I did choose the 6-French system because I didn't want to change to a 7-French system due to the antegrade access in an operated groin. So, any questions?
Dr. Zeller.
up to this state of the procedure.
So if you had
Yeah.
gone subintimal approximately there, which is, there's obviously a very significant risk of that, would you have considered a retrograde option?
No, I'm sure. Okay, if I would have gone, yes, of course. Yes, of course. I would have considered a retrograde access because the distal landing zone of the anterior tibial was nice. So this would have been my second choice. Here I was able to cross in true lumen, so there was no question to use a retrograde access. This is an interim's result after the first pass with the atherectomy system, and this is where we are now at the moment. So this is the result after Phoenix atherectomy. There's a channel created, there is some focal thrombus present, and I'm now prepared to introduce a drug-coated balloon. In this particular case, I have prepared a 5 by 150 millimeter Ranger balloon. This is a low-profile drug-eluting balloon, and I did consider not to use a pre-dilatation balloon here because I'm sure that due to the low-profile nature of this particular DCB, I should be able to get access to the popliteal artery without pre-dilatation. So this is the outflow. Yeah, we can see the reconstitution of the anterior tibula. Good. Okay. So, alles gut, gell? So now I'm going to introduce the drug-coated balloon. As mentioned, it's the Ranger balloon from Boston Scientific.
Dr. Zeller, are you concerned about drug absorption at all without pre-dilatation here?
Well, to be honest, it's an unknown. We don't know whether pre-dilatation does result in a better drug absorption to the vessel wall due to micro or macro fissures induced by pre-dilatation. It could be, it's not proven yet. You may be aware of the first-in-man outcome of the Illuminate studies. There had been two phases of a single-arm study. One phase of 50 patients did perform drug-coated balloon angioplasty without pre-dilatation. Another 50 patients had been treated with DCB following pre-dilatation. And between both cohorts that had not been randomized, there had been no difference in terms of patency up to 2 years. So we don't know whether pre-dilatation is really essential for improving the drug uptake. So what I'm personally interested in is your current strategy regarding the use of drug-coated balloons before the FDA panel meeting in end of June. Are you still using drug-coated balloons, or are you pausing at the moment?
I think overall
Spüren Sie
the
was in der
usage
Kniekehle?
is reduced
Spüren Sie was in der
as
Kniekehle?
it's mainly a legal problem for us and not so much a scientific problem.
And I think that's true all around. This is Larry Diaz, Dr. Zeller. In my hospital, the legal team has advised to withhold the use of drug-eluting technologies for the time being until the panel reconvenes at the end of June.
But I would argue that in this space, we're across the joint. DCB is designed specifically for this type of space. I mean, ideally, you would want to avoid putting a scaffold across the knee.
Yeah, I believe that this particular kind of lesion does fit exactly into the recommendation of the second FDA letter. This is a complex lesion which deserves a kind of drug-eluting technology, and in particular in the knee joint area. Of course, you could consider the use of a superior stent here, but trying or aiming for a stentless approach is definitely the way to go here. So Greg had been talking about the correct technique of balloon angioplasty. We are following this very much, so we really inflate our balloons, and this is independent whether this is a drug-coated balloon or an uncoated balloon for at least 3 minutes. Below the knee, we even use up to 5 millimeters of inflation time, and we really have the impression that using this kind of balloon angioplasty strategy, we can improve the outcome.
Yeah, it's just part of the lessons that we learned from the Levant 2 study, right? So, and you're using like a 1.1 to 1 ratio, right? Balloon to artery, in order to improve.
Exactly. Usually, exactly. I'm intending to use a balloon which is slightly bigger than the reference vessel diameter. This guarantees you full wall apposition in all parts of the lesion, and with this, the best possible drug release into the vessel wall. So I did start the timer with a little bit delay, so we are about 3 minutes now with balloon inflation. And I will give you an interim angiogram after this angioplasty here. Oops. So what happened? Maybe I did squeeze some thrombus into the origin of the anterior tibial.
Does the balloon cover the entire length of the
balloon? No, it did not. It did not. So I'm just pulling back the balloon for a few centimeters. Here you can see the waist.
Like there was a spot.
This is probably the reason for no flow. Yeah, and the shaft, the balloon shaft was probably big enough to occlude this segment. So before inserting the second drug-coated balloon to cover this segment as well, I just predilate this with the already used DCB here. So now we should have some flow established. I will pull back the balloon before I inject more contrast here. Once again.
So asking the panel here, how many of you would use some type of scoring technology?
I probably would have, but I do sort of agree that there's not a lot of data, and if you think about it, if you do that and then use a DCB, you're just doubling the injury. So I've kind of converted more to going straight up with the DCB just for that theory alone, but again, it's kind of a data-free zone.
I tend to prep the lesions pretty aggressively with either atherectomy or some sort of scoring balloons before DCB, but that's just been my practice.
Yeah, in general, I use one or the other. It depends on, of course, what kind of lesion you have and so on and so forth, but I always use either atherectomy or I use a focal force type balloon technology before I use the DCB.
What kind of atherectomy system would you use here in this indication? Jet stream or directional atherectomy?
In my practice, we use the jet stream preferentially.
Yeah, or Phoenix.
Okay.
I've used it below the knee. It's pretty easy to use.
Yeah. So what I was using here was the 2.2 millimeter Phoenix atherectomy system. So I'm inserting now an even slightly bigger balloon, so a 6 millimeter balloon for the proximal section of the former occlusion. And finally, this will be done offline due to limited transmission time. I will also perform a below-the-knee drug-coated balloon angioplasty, and I will leave the tibiopinal trunk untouched today. It's probably something for a second intervention in the near future. But I believe if I could achieve a good outcome result with the drug-coated balloon in the anterior tibial, then it should be fine for the lady to resolve her rest pain.
That's great. What kind of balloon, what size balloon are you planning on using in the BTK space?
She's very small and a tiny lady, so I will use a 2.5 millimeter balloon, and we have a special balloon available which is 30 centimeters in length, so I'm more or less able to cover the entire anterior tibial with one single drug-coated balloon here.
Nice.
This is my intention, yeah. Yeah, I don't know what we could discuss else, because I believe it's not so interesting to watch now the balloon inflation for 3 minutes.
Well, we could argue about the total dose of drug that is going to end up being delivered with the 2 DCBs in the supra-popliteal space, and then another long 2.5 by 30 centimeter below the knee. So what are the thoughts on that?
Well, basically what we just submitted for publication is a dose analysis of the 3 studies with DES and DCB with 5-year follow-up. And we did have a look on it. And there was absolutely with no device, not with the Silver PTX nor with the DCBs, with 5-year follow-up, any correlation between dose based on individual calculation on each single DCB or DES device which had been used within the study procedure. So in all those 3 studies, the highest dose device had the lowest mortality rate. And we did divide the analysis into 3 terciles: low dose, medium dose, and high dose. And in none of the 3 studies with 5-year follow-up, there was the highest mortality seen in the high dose cohort. So what does it mean for me? It does mean that there is no dose correlation between paclitaxel exposure and mortality. And therefore, I'm not so hesitant to use overall here 3 drug-coated balloons, in particular considering that the 3rd balloon is a very small balloon, 2.5 millimeter dimension only, so the overall drug dose is relatively low, even if it's a 30 centimeter long balloon.